The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. My name is Jorge Zárate, and I'm one of the chief residents in general surgery at WashU. And today we have Dr. Stephen Hunt here to review the management of malignant disease of the colon and the rectum. We previously recorded an episode discussing benign disease, and today we're going to focus on malignant disease. Dr. Hunt is a professor of surgery at Washington University in St. Louis in the section of colon and rectum surgery, and he did both of his residency and fellowship here with us at WashU, and you will recognize his name from several NCCN practice guidelines. He's also one of my personal mentors and heroes.
Well, thank you for having me, Jorge.
All right, so like we just discussed, we have already done one of these episodes discussing benign disease, and there's so much in our colon and rectum chapter that we've decided to split up the malignant disease and what we're going to be focusing on for this chapter. So let's dive right into it. We have a gentleman, 47-year-old male, who presents to clinic after their very first colonoscopy. He got a call from his GI endoscopist that said that the pathology from a polyp that they removed from a cecum came back with a focus of adenocarcinoma, and they're asking what to do with him next.
So we see these patients a lot. Generally, once a week, I'll see a patient in clinic with that exact scenario. And the first thing you need to do is get a copy of the colonoscopy report and a copy of the pathology report. The colonoscopy report, what's really important is the morphology of the polyp. Was it sessile? Was it flat spreading? Or was it a pedunculated polyp? Pedunculated polyp, that's where the Haggett levels come from. And a patient with a Haggett level 3 polyp, as long as it does not have any alarming features, pathologically is a safe patient to watch. And by the alarming features, I mean perineural invasion, I mean lymphovascular invasion. Some of the times we can even get our pathologists to look at tumor budding in these polyps, and all high level of tumor budding also portends a little more, higher chance of it coming back in the lymphatics, and that's the thing that we're worried about certainly for a Haggett level 3 polyp with a negative margin. We're not worried about a local recurrence of that polyp. We're worried about disease in the lymphatics. Now, a sessile polyp is a bit of a different animal. There's a lot of literature, especially from rectal cancers, that the risk of lymph node involvement is directly proportional to the depth through which the tumor invades the submucosa. Okay, that's why for a Haggett level 3 polyp, that polyp is not invading, or that cancer is not invading the submucosa. We know that because it's out on a pedunculated polyp, and so it's not even into the submucosa. But a sessile polyp invades the submucosa, and the majority of polypectomies do not. They get the mucosa and they get the submucosa, but we have no idea the depth. The proportion of that submucosa that's invaded, and generally what's called an SM, submucosal level 1 invasion, is the superficial third of the submucosa. Those polyps have a very, very low risk of lymphatic invasion, provided they don't have any of those other concerning features. A polyp that has SM3 invasion that's more than 2/3 of the way through that submucosal layer, that polyp has up to a 20% chance of having spread to the lymph nodes, having positive lymphatics. So with sessile polyps, we don't have as good of a clue because we really can't tell the SM level of these polyps. So we have to use our other clues. What was the size of the focus of the polyp? We know that the smaller polyps, less than 5 millimeters and down, those polyps tend to have a little bit better behavior than the larger polyps. And then we have to look at if there is truly submucosal invasion, and then does it have any of these other features that alarm us, perineural invasion, lymphovascular invasion, et cetera. And then what is our margin? And then where is the polyp? I mean, if they take out a polyp like that, that has some concerning features and it's in the rectum, that patient might be amenable to some sort of transanal procedure. And we have a relatively low threshold for doing that because it's a well-tolerated procedure with very little risk. So a patient with a mid-rectal polyp that was 4 millimeters, and a close margin, a 1 millimeter margin. That patient, I'm almost always going to offer them some type of transanal excision, full thickness, just to completely take away the chance of a local recurrence, and then to allow us to maybe better assess the risk of lymph node metastases. A patient who has a polyp in the rectum with a positive margin, I might just offer them a transanal procedure also, because again, we don't know how deep that polyp was, but when we go out and we take out the scar, we can see, number one, if there's any cancer left, and if there is, how deeply it invades into the submucosa, and stage it better. If it's an SM3 cancer, I'd probably talk to that patient about having more radical surgery. Now, more proximally in the colon, you can get you can do a submucosal excision endoscopically, but doing a muscularis excision is much harder, and some of our advanced endoscopists can do these things. But in general, those patients with polyps above the rectum, we have to really ask all of the questions, and I always will have that pathology reviewed, and I will almost always present it at our multidisciplinary conference, because I want the pathologist to tell me, what are the adverse features, what are the margins, et cetera. And looking at a polyp, sometimes, in that type of discussion, looking at that polyp can give you better clues. And then you have to take into account patient factors. How well will they tolerate surgery, et cetera. Younger patients, I have a lower threshold for doing a colectomy on.
So you're saying, like, in contrast with something that's distal, you don't really have the option of a less invasive procedure, so you're really buying yourself a big oncologic resection.
Yes.
So you want to make sure that you kind of have really fleshed out what that polyp looked like to the best of your ability.
Exactly.
Okay.
Exactly. And then assess the risk. And every single polyp that has a cancer has some risk of coming back. Nothing is absolute zero. But you want to assess that risk, and you want to talk to the patients about it, and make that, again, an informed decision.
So if instead of a polyp, it was a frank mass in the cecum that was biopsied by GI and did come back as adenocarcinoma, and they're, in your clinic here, they haven't, for some, let's pretend that they haven't had any workup for this. So, like, what's all the staging that you need to get for a colon cancer? So,
when I was training, it was chest X-ray and then CT abdomen and pelvis. Now, and that's how most patients still show up to me, is they've had a CT of the abdomen and pelvis, but not a CT of the chest. But those patients all end up going back to the scanners and getting a CT chest, abdomen, and pelvis. I want to look at their colonoscopy report. I want to make sure that there's not some other polyp that they didn't remove, but they're so overwhelmed by this horrible cecal mass that they kind of gave short shrift to that other polyp, and then that we need to address.
It's sort of like the concept of a distracting injury,
exactly,
trauma, right?
Exactly,
Yes.
And it's kind of the same thing, and it's the onus is on us as the surgeons to really read over that colonoscopy report, make sure they made it all the way to the cecum, make sure that they didn't find any other masses or other polyps that they were unable to remove. And then, CEA is part of the staging workup. And for colon cancers, that's it. Okay, that's it for the staging workup. And then schedule them for the appropriate surgery if they're candidates.
Sometimes it'll be patients who could not complete their colonoscopy because, the mass was, so distal that they weren't able to traverse. Even if they're not clinically obstructed, sometimes I feel like I've run into this where the scope couldn't pass through.
Right. So a more proximal tumor, say a mid-transverse colon cancer that they couldn't navigate beyond, those patients will generally just get an extended right colectomy. Okay, that way, if there is any pathology proximal to that, we remove it.
Because you can't rule it out, correct?
Because you can't rule it out. We might get a CT colonography, but oftentimes those are not very telling with these endoscopically obstructing cancers. Now, a more distal cancer, if somebody has a mid-sigmoid cancer, I'm not going to take out their entire colon because we weren't able to assess it. So generally, in those patients, we'll do the appropriate operation, which for a sigmoid cancer would be a sigmoid colectomy. Two choices. One is intraoperative colonoscopy, and I'll do that if I think that the patients will tolerate the prep and have a good prep. But more often than not, those patients don't have a great prep if they have endoscopically obstructing lesions, and so I'm not even going to bother in the operating room. I will wait till they've had their surgery, they've recovered, and within about 8 weeks, usually we'll set them up for a follow-up colonoscopy. A rectal tumor that is obstructing oftentimes, again, we will take out the tumor, do the operation, and some of those patients end up with a diverting loop ileostomy. Before I close the ileostomy, I will do a colonoscopy on those patients. Oftentimes, those aren't the best colonoscopies because they still have inspissated stool in their colon, and you cannot clear that. Irrigation does not clear inspissated stool out of the colon. So, if we give it a college try, we do their colonoscopy. If we get a pretty good look and we have a pretty good idea of everything that's going on with the rest of their colon, and then after we reverse their ileostomy, a month or so, we'll have them prep and then come back and get a full colonoscopy with a good prep.
Okay, so they got the chest CT that you ordered, and unfortunately they found some mets in the lung. And then maybe our radiologist overread the CT, and maybe there's also a suspicious lesion in the liver.
Okay. Generally, with metastatic disease, widespread metastatic disease, that patient is probably never going to come to an operation unless they're symptomatic. So, and that's why I asked them about abdominal pain, about you look at their presentation, were they profoundly anemic? If they were just a little anemic and you think they can get by with iron, most of these tumors will have a decent response to chemotherapy. And so usually we try to avoid surgery up front because a patient with widespread metastatic disease, they're going to die from their metastatic disease, not from their primary tumor. So we want to get them to chemotherapy as fast as possible. Now, if they have a tumor that is bleeding and they have widely metastatic disease, sometimes surgery is the right answer. Sometimes radiation will address the bleeding, and that's kind of case by case. But if somebody's not going to do well with surgery, I'll ask the radiation oncologist to radiate the primary tumors because that'll stop the bleeding almost immediately, and it's usually just short course, 5 days of treatment. I'm not exactly sure the exact doses, but it's usually a short course of treatment that will take care of the bleeding, and then those patients can get right on to chemotherapy. If they have oligometastatic disease, a single lung lesion or 1 or 2 liver lesions, a lot of times what we'll do is send them to the oncologist, let the oncologist treat them, and our general practice is usually to give those patients about 4 months of treatment with chemotherapy, reassess their liver or lung disease, and then plan. If it's a liver disease, we'll usually plan a combined procedure with our HPB surgeons. And if they're going to do a big liver surgery like a trisegmentectomy, we'll do those as stage procedures. But if it's a smaller procedure, little wedge resection or
ablation.
Left ablation or left lateral lobe, usually we'll do those together. Mm-hmm. And then there's the patients who have widespread metastatic disease but are young. And those patients, you want to try everything. And I'm talking liver specific disease. We do a lot of hepatic artery infusion pumps because that will increase the lifespan in those patients. And when they go to put in the hepatic artery infusion pump, I will usually do their surgery synchronously at the same time.
I guess to round out the discussion, which of these patients, what is the role of adjuvant therapy in colon cancer?
So certainly for stage 3 colon cancer, those patients deserve to meet with the medical oncologist. While the NCCN has not adopted them, a lot of the circulating tumor DNA is being used by medical oncologists to decide with these borderline tumors, a stage 2B cancer, and they're following even some stage 2A cancers with these circulating tumor DNA. Now, NCCN says that it should not weigh into your decision making as far as adjuvant chemotherapy, but that will change as the data matures over time. So I've gotten to the point where any patient with a stage 2 or higher cancer, I'm gonna offer them a visit to the medical oncologist because, number one, the medical oncologists are a lot better than us surgeons at their surveillance postoperatively. Mm-hmm. They don't mind doing it. They have cadres of ancillary help who are meant to kind of supplement that part of their practice. So anybody with the stage 2 or later cancer is going to go to a medical oncologist, and I let them make those decisions. One thing I will tell my patients in general, and the medical oncologist may not like this, but the data between 3 months and 6 months of chemotherapy shows that they are almost exactly the same. While there's a significant difference, it's not a clinical difference. It's like a 1% difference in outcomes between 3 and 6 months of chemotherapy. So I will suggest to my patients that they consider the 3-month option, because the toxicity from oxaliplatin, with the neurotoxicity from that, can last a really long time, and it can be debilitating for these patients. And that toxicity in a patient who gets 3 months of chemotherapy is dramatically less than 6 months. So that's the only, I don't try to prejudice them in any way, but I try to get them to lean towards doing the 3 months. The oncologists, most of our oncologists are still pushing for 6 months of chemotherapy for these patients.
Okay, so different scenario. This gentleman that came to see you, instead of having a tumor in a cecum, has a rectal sigmoid tumor. And so how do you go about discerning, is this a rectal tumor or is this a sigmoid tumor? So
anybody that comes into my office that has sigmoid or lower cancer is going to get a rigid proctoscopy in the office. And if they're unable to tolerate that, they're going to get a flexible sigmoidoscopy. Because lots and lots of patients will come to you as a, quote, sigmoid cancer, and it is upper rectal, at 8 to 10 centimeters. And the GI folks are kind of looking down at their scope and they see 20 and they're like, oh, we're still in the sigmoid, but the 20 is at the cheeks and not at the anal verge. And so any patient that comes in is going to get a rigid proctoscopy or a flexible sigmoidoscopy. I have to rule out that cancer is, and I have to make sure that cancer is not in the rectum, because the treatments are very different. A rectosigmoid cancer, an upper rectal cancer that is above the peritoneal reflection, is generally just going to get a low anterior resection or an anterior resection with no neoadjuvant radiation or any other treatment. Okay, patient. If I go to look and it looks like it's mid rectum, and distances are hard to use because for a lot of the research studies, 12 centimeters has been the cutoff. For between a rectosigmoid cancer and a rectal cancer, but everybody's different. You have to, a tumor that's at 14 centimeters in a big guy is probably a mid-rectal cancer. That's looking, with a rigid proctoscope. But I always look, and then I assess, where am I in relationship to that curve of that rectum? If I've pushed around the curve of the rectum and I'm way up in the upper rectum, then I know it's something we're going to treat as a colon cancer, not as a rectal cancer. But if it's mid-rectum or lower, or if it's a really big, bulky tumor, those patients are going to get an MRI as their first staging exam, okay? Yes, they're going to get a CT chest, abdomen, and pelvis, and yes, they're going to get a CEA. But the most important thing in their treatment is the MRI, okay? Because on that MRI, we're going to look, where is the tumor? Is there a lot of lymphovascular invasion, extramural vascular invasion? You can see that on MRIs now pretty well. If it's a stage T3 cancer, if there's any lymphadenopathy and it is indeed a rectal cancer, most of the time that means below the anterior peritoneal reflection. Sometimes even higher if it's a bad actor, if it's got a lot of extramural vascular invasion. If they have that, and even upper rectal cancer, a lot of times I will still suggest that those patients get radiation. So really bad actors that are more proximal to the rectum, but that are big bulky cancers or have the extramural vascular invasion, and then anything T3 or N plus from the mid-rectum down is going to need neoadjuvant radiation. And then lastly, pretty much any rectal tumor where the circumferential resection margin, especially the sacral margin or the pelvic sidewall margin, those patients need to also visit with the radiation oncologist, because the biggest risk of local and distant recurrence is that threatened circumferential resection margin. And if they have that, even an upper rectal cancer with a threatened posterior circumferential resection margin is at high risk for recurrence. And so I would recommend that those patients have neoadjuvant radiation. And we do total neoadjuvant therapy. And our version of that is short course radiation followed by 4 months of chemotherapy. And while short course and long course for total neoadjuvant therapy have not been compared ever prospectively, there is a trial coming out of Germany that's going to give us the answer to that. But we've been able to manage a lot of these patients with radiation, chemotherapy. And then when they come back to our office, at about a month after they finish their chemotherapy, we will reassess them. We'll get another MRI. We will do rigid proctoscopy in the office. If there's an obvious cancer, then I'm going to go ahead and set them up for surgery. If on rigid proctoscopy I don't see the cancer or it's a flat white scar, the MRI looks good with no more lymphadenopathy, I'll then set that patient up for a flexible sigmoidoscopy and consideration of non-operative management. So what we know right now is that patients that you take all comers with rectal cancers, not these big bulky tumors, not these big T4 cancers, but
because those are obvious surgical candidates, right?
Right. Mm-hmm. And it's hard. A big T4 cancer that's multivisceral, that's not one you're going to want to follow with non-operative therapy. Mm-hmm. But a smaller rectal cancer, even a T4A rectal cancer has a chance of having a response. But basically, if you take all comers that with locally invasive or local regional rectal cancer that's not too advanced, if you take all comers and you treat them all with total neoadjuvant therapy, radiation followed by chemo, about 50% of those patients will have a complete clinical response. And that is by MRI, by digital rectal exam, and by endoscopy. And if all three of those things agree, then it's safe to manage that patient with non-operative management. And I tell every patient that walks through the door with a rectal cancer, the first time that I see them, if I think that they potentially could be a candidate for non-operative management, I will mention it to them. I don't want to get their hopes too high, but I want them to at least be thinking along those lines, because I don't want to surprise them when they come back after their total neoadjuvant therapy. Because
some patients will be expecting surgery and they will be confused.
Yeah.
By that. Yeah, I see.
And I also, you need to give them, it gives them a little bit of hope, because these patients are oftentimes devastated when they come into your office, and you just say, there's a chance that we may not have to. I don't play it up too much, but I mention it to them. And then if they do have a complete response, what I tell them is that, okay, that's great. You've had a complete response. About a 1 in 4 chance that you are going to have regrowth of this tumor, either on MRI in the lymph nodes. That's a smaller percentage. That's about 5% of the regrowths happen in the lymphatics and not at the mucosal level. But most of them we find endoscopically or on physical exam. That's how we find almost all these regrowths. So of the 50% of patients that have a complete clinical response, 3/4 of those patients will never have their rectum removed and will live the rest of their life cancer-free. And then 1/4 of those patients end up getting a proctectomy at some point.
And just to clarify for the folks at home, what does non-operative management look like?
So currently, and we just revised the NCCN guidelines for this, but currently it's every 4 months for the first 2 years, they get a flexible sigmoidoscopy. At 1 year, they get a full colonoscopy. And then every 4 months, at the same time as their flexible sigmoidoscopy, they will get an MRI. Now, most of these patients that we manage with non-operative management have tumors that are palpable, so we're able to actually feel it on our digital exam when we do their flexible sigmoidoscopy. We have, if you look at the Brazilians, who were the initial people that started doing non-operative management, they will not do non-operative management on somebody if they can't feel the tumor. The way we've adopted it in the United States, we are doing that. And it hasn't shown to be any worse. Most of the things that you can feel, you can also see on endoscopy if you're experienced. And that's the important thing, is that people that are treating these patients non-operatively have to have a lot of experience, because there are so many nuances in how you take care of these patients that it can't be something that you just dabble in.
So, Dr. Hunt, who would be a candidate for a transanal resection?
So there are many candidates for transanal resections, but just to give you a quick laundry list of patients who have rectal tumors that are amenable to this, meaning that they're generally less than 2/3 of the circumference of the rectum, benign tumors. Those patients are good candidates if those polyps are generally below 14 centimeters for a transanal excision. When I say transanal excision, I could either mean standard transanal excision with an old-fashioned Hill-Ferguson scope. I could mean a TEM excision with the TEM scope, which isn't done very often now, and then more commonly is either laparoscopic or robotic TAMIS, transanal minimally invasive surgery. So patients that would qualify for that would be, number one, benign polyps that are usually less than 2/3 of the circumference of the rectum. and amenable to resection, meaning that you can fit them in the scope and that they're not just blanketing the whole rectum. I often will bring patients who have had polypectomies for cancers with unclear margins or with unclear SM level invasion. I will bring those patients in and do a transanal excision of that scar. Patients who have had carcinoids removed endoscopically, oftentimes those will have a positive margin, and I will bring those patients back and just excise the scar. And we looked at our data for those patients, and 1 in 10 of those patients actually has residual carcinoids. So, you can question the utility of doing that, but it is helpful, at least in a little more than 10% of our patients. Patients who have been managed non-operatively for rectal cancer, who have a complete clinical response, or who have a clinical response and we can't tell if it's just maybe a little bit of adenoma that's left behind, those patients are candidates for transanal excision. And then, there's a various laundry list of other reasons we do it, but those would be the main reasons. Early stage cancer, a T1 cancer that has a otherwise completely normal MRI, especially a low T1 that where the radical surgical option would be either a coloanal or even an APR. Those patients, I'm going to have a probably a lower threshold for offering them a transanal excision.
And how do you feel about TAM as compared to TEM?
TEM, when I did it, was great because it was kind of revolutionary and it changed things. But I did it up until last year, and the equipment has not been advanced because everybody's moved towards TAMIS except me until a year ago, and I realized that I was way behind the times, and I've started doing these. If it's a higher tumor, I've started doing just the robotic TAMIS, which I think is a phenomenal procedure. Because I can't believe I did TM for as long as I did, because I should have just been doing the robotic TAMIS procedures. So much easier.
Well, all right, we covered a ton of material on malignant colon and rectal disease. Please also make sure to check out our other episode on benign disease as well. Thank you so much, Dr. Hunt, for your time. And if you're looking to learn more about colon and rectal disease, please make sure you check our chapter in the Washington Manual of Surgery.
Thank you.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zárate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.